So welcome everybody. This is our next COVID and cancer webinar series, and we have a wonderful panel of experts. Today we'll probably be discussing two topics, and we may not have time for the third one. For the first topic is on PPEs, and Dr. Amol Patel, Lieutenant Colonel Amol Patel, who's a medical oncologist from the Indian Army, will be sharing his thoughts and moderating that. And then Dr. Ullas Batra will discuss a lot on oxygen and steroids, and which is, I think, the most appropriate and most effective way of treating our COVID patients. For the discussions today, we have a galaxy of panelists. Dr. T.P. Sahoo, who is a program director, is of course there. We have Dr. Nandita and Dr. Dheeraj from United Kingdom. Both of them have been at the cutting edge of the peak of the second wave in United Kingdom, and I think we will learn a lot from them. We have Dr. G.C. Kilnani, who's previously was head of department at AIMS and now is director at PCRI. And as he mentioned, he is probably seeing hundreds of COVID patients on a daily basis. Then we have three people from Tata Hospital. Sheila is in charge of the anesthesia and intensive care, and she's also on international bodies. And as we discussed yesterday, she has actually been instrumental in bringing out some guidelines using the Delphi method. We have Dr. Anant Ramaswamy, who's an adult medical oncologist from Tata Hospital. And then we have Dr. C.P. Badira, who's a pediatric oncologist, also from Tata. And they have been, managing cancer patients right till the middle of the night. In addition, I think Prashant Mehta will join us, and he is also very active in management of COVID patients. So with this little bit of introduction, I hand over the first session to Dr. Amol Patel. Over to you, sir.
Amol, so would you like to share slides?
Yeah, I will share my slides.
Sure.
So good evening, Professor Parikh. Good evening, Nandita madam, and whatever all the panelists. I can't see others. Hi, Anant.
Hi, sir.
Hi. So I'm a medical oncologist at INHS Ashwini. And today my job is to speak on PP, what are the ill effects of PP.
Sir, Amol sir is just logged out. I believe he's having a network issue.
Maybe he has gone to wear his PP. Get out of his. He's doing doffing of the PP.
उल्लास इस पे सिर्फ पारिक सर हंस सकते हैं, by the way.
No.
और कोई नहीं हंस सकता.
See, you are smiling on this.
But I think, Sheila, while we are waiting for him to come, can you just share the challenges that you have faced while doffing and donning PPEs, and what problems residents have who are on duty for 8 hours, 12 hours?
Right. Thank you very much, sir. So, as you're all aware, this personal protective equipment, even for us in the intensive care unit, was something very new. And we were not, not only availability, but, how to don, how to doff, was something that people were not even familiar with. But fortunately, because of the lockdown and because the pandemic started a little late for us, we had time to do this kind of training. So initially we started with residents in lots, but it was getting so challenging. And also we would have to waste a lot of personal protective equipment. So this was a real challenge. And so we started making videos which we could circulate and get people to, familiarize themselves with donning and doffing. And especially doffing was the most challenging one, because that was the time when you can infect yourself, and that had to be done properly. The other biggest challenge was not only putting on and taking it off carefully, but being with a personal protective equipment. Now, if you work like us in the intensive care unit, we have 8-hour shifts. So 8-hour shifts continuously with personal protective equipment. And in the beginning of the pandemic, we had, shortage of PPE. So we could not have people, going out, drinking water, going to the washroom. We even had to have some people wearing diapers if they were there for a longer time, because it was just not possible, because it was, dangerous for them to, doff and wear the same PPE, and we had very limited supply of PPE. So these were real challenges. And the other thing is, whatever procedures you did, which you were regularly, familiar with, intubation, everything was becoming very challenging, because you would have this, face shield, you'd have your goggles, you'd have everything which was, fogging your vision, and so much discomfort. And the most challenging of all was, I would not know who the sweeper is, who the nurse is, who the intensivist is. And that was becoming, once I was shouting at one sweeper, come on, give adrenaline. And she was just looking at me. And, things like that. I mean, we faced very unique challenges, and then we started labeling ourselves, putting nameplates on so we faced very unique challenges, and we evolved as we went along with, the time, as to how to use it safely and effectively.
Right. And Nandita, you mentioned in the previous session that there are specific measurements taken about the size of the mask that you need to wear and the parameters that you have looked into. So would you like to share your thoughts on that?
Yeah, this was during the first wave, and I'm sure Dheeraj must have had the same experience as me. Is that during the first wave, we didn't know anything. This was March 20, and I was supposed to go out. So in February, we started our testing, because we knew that things were coming from Italy, had been affected, and it was coming westwards. So the testing was done, and there were a few masks which we were tested. And if we failed that, we were tested on another mask. And then we knew sort of which mask, and they had written it down, that which mask we have failed and which mask we have passed. And then it happened. We were very lucky in our intensive care. We did not get a shortage. Our trust looked after us very well. I can tell from the critical care point of view, so where we were looking. We had the same challenges, as some people did not pass any of the masks, then they had to have a special, the one with the filters and all that. So that sort of mask was there. So for the second wave, the masks which were remaining, because the first set came from China, I think, and then some of them were withdrawn. So the other time, then I had to wear the other mask with filters, which was because I had failed all the other ones, and there was, I came in the high risk category. The same problem, we had shifts of 12 hours and 12 hours, or 12, so 13 hours. So of course we used to get a break after about, say, 6 hours or something. But once when I was turning a patient, actually I was crying underneath, because the mask had gone into my cheeks and it was bleeding. But I could not say anything, because I was proning a patient. And you know how it happens when proning, and it was one of our nurses. So one of our nurses was the patient. We were proning the patient. The head was in my hand. The mask was going in. I was trying to tell them, say, okay, now turn, now, because we have a proning protocol as well. Just nothing happened. And I could not do anything. I just afterwards as well, remember with that, that couldn't say to, and because nobody could hear you. You can't hear them, and they can't hear you. Sheila, maybe the same problem, isn't it? We don't know. We were writing on our backs who it was, because nobody would know who the consultant is or who the nurse is and everything. We did that. And even after coming out, I could not go out, because there were so many people requiring proning and this, and some people were arresting, that I couldn't come out till much later. And the scar from the first thing is still there. So this was last year March. It's still there. It's bad, because it was, and I'm sure everybody must have had the same experience, and everybody was coming, crying. We used to sing songs. Now this time in that PPE also, we have put on music, ABBA music and all, and we are singing and dancing, because just to keep up the spirits. The other thing is not going to the loo for ages and dehydrate. And once I came out, and same thing is, the entire face was crusted. And I was thinking, what is this thick? It was because I was so dehydrated and so this dry skin that I feel over this whole year, my complete skin has completely gone. When you come and say, oh, we'll rest, we look at yourself in the mirror, it's horrible. But we were lucky.
Can we go back to Dr. Amol now?
Yeah, please. Sorry.
So Amol, sorry, I was just trying to ask a few questions while we lost you. Go ahead, please.
Yeah. So can I share my screen now?
Yes, please.
Sure.
The screen is visible?
Yes, you can make it screen.
Yeah.
Yeah, perfect. Thank you.
So, good evening, Professor Parikh, Madam Nandita, Dr. Dheeraj, all. Who else is there now on the screen? Dr. Khilnani, Professor Khilnani, Dr. Amish, Anand, and hi, Dr. Ullas. So it's a great pleasure to have a meeting during this crisis, and it's good to see all of you in person. So topic given me today is the personal protective equipment and basically its ill effects. So we did some survey last year, but it is not a one-way traffic. I'm not just going to talk about what we did, but it will be interactive session. So, Dr. Ullas, I know being research inquisitive mind. So, what the first thing came in your mind when you started wearing this PPE?
Oh my God. How am I going to survive this? How am I going to breathe in? Am I going to get infected while donning, while doffing? Is there a separate room for donning, doffing? And how did it, as you rightly said, when did it start? Is it good enough or not? What quality of PP? 100 questions came to our minds. Mind.
And if you go back to the history, so it was just those, the honey makers and those protection from the bee. This is how the PP started. And the Leonardo da Vinci in 14th or 15th century for protecting his armor or all the soldiers, they made some metal equipments, and that's how the war were fought. And after the Ebola outbreak, it became the universal phenomena to wear the PP in case of such deadly virus outbreaks. And it was the month of May last year when for the first time I wore this PP, and this time I realized that it is not a easy thing. What is happening? If once you wear the PP, Dr. Amish, what are the metabolic changes you are going to see as per, what will happen if you wear that N95, tightly packed? What could you guess what metabolic abnormalities will take place in your body?
Amol, very difficult question you asked. Fortunately or unfortunately, the highest amount of time I have worn PP for days together is 6 to 7 hours, and luckily I couldn't feel anything, honestly speaking. Nothing, no change at all. But what I have heard from many people, that dizziness, giddiness, headache, probably these are the signs of CO2 retention. It can be one of the reason. It's like same non-rebreathing mask we do in anxiety.
So let me frame other way. What factors can lead to the problems in case you are wearing PPE? This is a new thing for all of us, for doctors. It's not easy stuff. There's the temperatures of such kind of 40, 45 degree last summer. This summer also the same thing. Humidity so much. Then doctors have their own physical the illnesses, prior illnesses, maybe diabetes, hypertension, hypothyroid. You name thing. Many things are there. Then these psychological issues. So is there any interplay? We don't know. So we did some literature review, and there were many case reports and some series on the skin toxicities. And there were some irritation and a number of skin related issues that were easily managed. One of the study from Singapore mentioned about the nasal resistance. And there's another good study from Singapore again. They described about the headache and the new onset headache and the aggravation of the previous headache. Another one is the same thing about what I was just mentioning about if we are going to wear that PPE for a long time or the N95, will it lead to hypoxia or hypercapnia or both? And this was a study registered at Taiwanese University Hospital, but in long back in 2010, but they never come with any results on this. So we thought that how to go and find out the ill effects on the physical and the neurological health of doctors and the paramedics. And we did that, and this was just published. It is in preprint in JAPI as a letter to editor. So what we did is the one-time survey of basically a cross-sectional study. We involve intensivists, physicians, nursing staff, technicians who are working in critical and non-critical areas. We defined the full PP as complete wearing of the hazmat suit, the coverall, N95 mask and face shield. And for partial PP, it's just N95 and face shield. So all majority of us who are working in the OPD predominantly areas, in that the partial PP is generally work. And we also defined this, we had categorized this PP use as a daily use into 3 hours and more than 3 hours, and also the duration, longest duration at a stretch, it is less than or more than a week. For this, because there was the AIMS Nurses Union strike was going on during that time, and we realized that beyond 3 to 4 hours of work, all nurses, they requested for shifts of the duties while going ahead with the all those PP work. So these are the ill effects. Apart from this, Dr. Anant, do you feel that there may be some more ill effects you have noticed from your colleagues or yourself at your hospital?
So my experience is based on taking rounds in the ward 3 times a week for around 6 months. So I'm just going to base it on what I experienced myself. And the round would be for approximately 2.5 hours, right? So initially, besides the obvious physical discomfort, I didn't feel anything. But from the 2nd or 3rd month onward, me and my colleague, we required around 15 to 20 minutes post doffing to, because we would feel lightheaded. And, our breathing rates went up, and this was informed to us by our colleagues who were with us, that, our breathing rates were higher, and we used to feel lightheaded. Thankfully, there was no headache per se, but definitely we felt a little dizzy after the first 2-3 months on constantly, having to go into the ward and staying there for 2.5 hours.
Okay, what's about Dr. Nandita? Apart from these effects, do you want to highlight more here? Being,
Lot of sweating inside when you wore that. It was, and I can understand if we had our peak during the winter coming into, we had that temperatures. I can understand lots of sweating suddenly, and then if the mask was slightly ill-fitting, then our glasses used to get clouded, right? You couldn't see anything. The first day I went into this, the visor, I went to do something and the visor fell on the patient. So what do I do? And then lots of thirst, extreme thirst, and throbbing headache that was there. And one thing was sore throat. Every time I put the mask on for a long time, when I came out, I used to feel, sore throat. And I used to come and mala COVID honar ka. This was a feeling because I didn't know whether that sore throat was, touch wood, I've been lucky I didn't have both during both waves. But I was scared because every time, and I just thought it was me. And then all my colleagues started saying, oh, have you had sore throat? Because everybody was scared of telling the other person that he or she has got sore throat. And it was because of the mask and dehydration. I don't know what others' experience was. Did they get the sore throat? I was scared at that time that, I think I have COVID now, because the viral load was so high. We used to intubate everybody in the first wave. So we knew that the viral load is high, they've come immediately, and you have a sore throat, you have a dry cough possibly because of that sore throat, and it was scary.
So exactly, Dr. Nandita, my wife, Dr. Manali Patel, who is also part of this article, she is intensivist. She works presently in Jaslok Hospital. That time she was in Medeor at Gurugram. So same thing. And after each bout of sore throat, we used to isolate again for next 7 days and observe the temperature. And she used to stay in a separate room. I used to stay in a separate room. Kids were in a separate room. So
Yes,
anyway,
we did the same for 3 months
say
in
3
different
months.
rooms.
And sometimes, fever hai ki nahi, to bas check karo, thermometer lagao. And the story keep repeating every time about the sore throat, certainly, yeah.
Yeah.
So in this study, the quite large number of people responded as per the Indian surveys goes. I think Professor Purvish will agree on this. So 216 the medics and the paramedics participated, and out of this 176 were wearing the full PPE. And at least one symptom was present in 86% of the participants. So these are baseline characteristics of the participants. Majority were the physicians. The nursing staff were around 20%. The components, the majority, I already said about the full PP. And to our surprise, not everybody was taking the SCQ. So only 60% of the participants were taking as a primary prophylaxis. And one very intriguing question we put in the questionnaire was the missing on simple prescription. So when we are working at our hospital, another ad hoc arrangement was made, and we were sitting in a non-AC environment. There was some arrangement. People used to come. We were on PP. So much of sweating. There was a difficult time in those days. Did you, Dr. Dheeraj, did you realize that there's some difficulty at the time of making some decisions?
I think, most of the things which you have said has been something which we have all faced, because it was a totally alien environment and we were dealing with a totally alien disease at this point. So on one point, you had to be absolutely up your game. And secondly, you were in a costume which was completely different. We've never done that. So, the common symptoms which we had was exactly, as Nandita said, a sore throat, worrying about what's going to happen. At the same time, the problem with vision, sometimes just having something on top of your head makes you very uncomfortable. It's just, you're not used to it. It feels like a very modular vision. Normally your vision's there everywhere. When you're looking at the patient, you're looking at so many different things at the same time. And here you actually had to move from one place to the other. You had to see the patient, then you had to see the ventilator. Your vision was getting affected quite significantly, I think, because of the plastic visor which was there on top. Communication was such a big problem. One of the things is that we had to literally shout. People couldn't hear what we were saying till the time where we had to come with some specific commands. Normally we are a very ultrasound heavy unit. We do ultrasounds, we do scan our patients, the lungs and stuff like that. Even the images appear blur. One of the questions where you had on, like, I want to remove my PP, that was literally situation sometimes where I just wanted to just remove it and then breathe a sigh of relief or a little bit of air and then go from there. But I think from our point of view, we were slightly different at that point, because we started having quite a lot of remote terminals outside. So we had a consultant in theater or in the ITU, and we had a consultant outside. So all the results and everything which can be done virtually was done by the consultant outside. The role of the consultant inside was just to examine the patient, look at what he could change there. So we work in collaboration there, because I think at that was a time when the teams came in. We had regular drills to practice this. So there's one consultant in theater or one team, either a registrar or a consultant, and the consultant sitting outside. So he had a broader picture of what was going on, while the person in the PPE was inside telling him the information. So I think we worked slightly differently, and at the same time, the logic was that, rather than every time you have 5 people doing a ward round, we had one single patient inside, one single person inside and person outside. And we justified this by saying the amount of PPE used in that situation is much lesser. So instead of 5 people going in, if one person goes in, you just have one PPE used instead of 4. So yes, it was a big problem, but I think there were smart ways of working beyond them.
So, Dr. Khilani, what was your experience with the SCQ?
HCQ.
Yeah.
If you ask me, I never believed in it. And
Great.
if somebody asked me about what do you think about HCQ, so my answer was, I'm not taking it. So they got the answer. So I never took it. And I was following the literature very closely. And I realized at the beginning of it that it has no use. So I can't actually pursue this conversation further because I never believed. I still don't, my prescriptions still don't have HCQs, neither they had last year because I do a lot of online consults. I don't stop it if somebody is taking it. I don't strike it, but I don't write it. And subsequently, several studies have randomized trials have, I need not quote them, have convincingly proved that it has no effect on viremia or viral load. Or that's my take on that.
Okay, so thank you, sir, for that remark. What about Dr. Ullas? Did you take that SCQ?
Like Amish, I took it. So it was the first wave. We weren't sure what is happening around. The guidelines kept on changing every hour, to say the least. So yes, I took it for 4 to 6. I think 6 to 8 weeks we took it. Then second wave we haven't taken it, but I took it in the first week.
Yeah. So along with azithromycin, Dr. Amish.
No.
Dr. Amish.
Azithromycin once. So that is something which Amol, you have brought it out very rightly. Forum after forum, webinar after webinar, and Khilani sir after Khilani sir have everybody said that, azithromycin, doxy, ivermectin may not be working. I have yet to see a single prescription in the city of Delhi which does not contain these medications. At least that is what I must have seen at least 300 prescriptions this wave, very less number compared to others. 100% of them had either of 2 of the 3 medicines, what you have said, but not as prophylaxis, as the treatment the moment COVID report comes positive.
Okay. So there is a really new science for everyone. We always wanted RCTs and systemic analysis and meta-analysis, but here we all have gone overboard and did whatever best we thought. Anyway, there's no much rocket science about this slide. This is just a kind of a common sense. Yes, headache was more with the full PP when people were wearing for more than 1 week. Anant has really already brought it out. Then there was also difficulty in decision making. Certainly, Dr. Dheeraj has also told about this. But somehow some physical factors, as there are people like Dr. Amish, they are very physically fit, though they never feel about hours to doff. Isn't it, sir? Okay, so yes, certainly we need to move forward, and we did another survey, but it is not published. But certainly we are now used to the PP. So Dr. Nandita, I think all these symptoms are now we are getting used to, and the symptoms load is reduced. So what's your take?
I feel we are getting used to it, first of all, as compared to the first wave, and it was something different. And that may be like wearing masks, maybe will be a norm for a long time, possible. One thing I just wanted to make with the PPE is the people forgot that they had not washed their hands in between patients. So that was very important for us to even still remember that is one of the problems which possibly led to more infections. And yes, we are getting more used to it, but at the still, as I said, if you stay for a long time and if you're dehydrated, not being able to go to the toilet is a big problem. And these things still will occur, whether, however, how many years, but we got some of your army PPEs which we use in the chemical suites as well. So they were really, really good. But at the same time, we were really sweating inside. So I continue to wear them. Some people now think because we have had both vaccinations, shall we go bare beneath the elbow because there is increasing infection. So people are thinking that as well. Oh, why do you need all these things? Now you both have had both vaccinations. So I had the Pfizer one, but I'm just saying that that's what was thinking. But I said, no, I'm going to wear it. I'm going to wash my hands in between each patient and maintain as much hand hygiene as possible with the gloves, of course. So that's what I do. That's my take.
Great. So people will not believe when I say that I don't use colistin. So certainly, Dr. Nandita, the hand washing is really important, and I transplanted 17 patients at Army Hospital. There's an autologous. Never ever use colistin. People get surprised. No, you are not saying the truth. But this is the way I look at. So we have a 2-stage washing system, and nobody is allowed to touch the patient unnecessarily. There is no way that patient is been touched by the paramedic. If it is required, then only. So yes, you're right. These things matters a lot. So just to conclude here, the physical and neurological dysfunctions were common among PP users. Certainly more than 3 hours and more than 1 week was statistically significantly that in the people who had that duration. Majority agreed for coining the term PP syndrome. That was a new thing, and that time we had wanted to do something for our own fraternity. So and people were agreeing that 80% wanted that it should be evaluated further. So yes, certainly there is a lot of scope to do the metabolic changes in the human body, or the more than 1 week or more than 6 hours we had. But that such kind of research really going to make a difference in coming days, because I believe these things will pose a further threat, and we'll keep using this PP for years together for next 2 decades at least. That's what my belief. So thank you once again, Professor Parikh. If any questions from any faculty or any members, please, I can take.
I have a question, Dr. Amol.
Yeah.
I think Amish has written in the chat box, CDC has come up with a new set of guidelines. So my question to the intensivists are they going to step down from that hazmat suit and everything? Is it the same that used in first wave, second wave? How is it?
Ilag maybe can answer that question.
Yeah, so I agree that, from the beginning of the pandemic till now, our understanding of, the infection has been a little better, and our fear, most importantly, our fear has kind of come down, and the kind of hazmat suits and the full protection that we were using and the complete cover and a lot of things we have evolved over time. So definitely, at least in the intensive care unit, what is recommended is get a FFP2 mask. So you wear your N95 mask, you wear your eye protection or the face shield. This is mandatory. But whether you should wear that hazmat suit and, have the full PPE, what we're doing is something more modified what people are using. And definitely you need a clean pair of gloves. So there are different versions of PPE that are now acceptable, and we know this is a respiratory infection. So the protection of the face, the oral cavity, the nose, eyes, this is paramount. And we just wear a fresh pair of gloves, and some places where we're dealing with patients could even just be a regular gown. So WHO has come down on its recommendations, and world over, not just in India, even in United States and different parts. When I speak to my colleagues in the intensive care, they have sort of scaled down on this complete sort of full PPE, as we used to call it, to a little slightly modified version now.
Okay, Amish has a question. I'm the moderator for the next one, but still, Amish, you and I are like Arnab Goswami, we have to give a comment, and this was not a PJ.
Ask questions, right?
So
my question is to Dr. Khilnani, sir. All these, scaling down of PPE is, if I understand correctly, is dependent on the virus transfer from inordinate substances or inordinate surfaces. What is your take on this inordinate substances, like, for example, doorknobs of ICU or the wards, and wearing hazmat suits, are they really making any sense, sir?
So, following this, whatever is coming out in the literature, nobody should talk about experience. Initially, we were very, very paranoid about, you go home, you shed your clothes, you wash your mobile, you take out your belt, your watch, your everything, then go through a different route into a washroom. It's like olden days, the sweeper used to when people used to make them walk from a different route altogether. But over a period, we realized that COVID transmission, the droplet and the airborne transmission is the most important. The fomites, as it is talked about, and I used to go on a television and there and talking about that in copper, it stays for 4 hours, and cardboard 1 day, and steel for 3 days, glass for 4 days, blah, blah, blah. But we believe now that that transmission is insignificant. What has taken over is that airborne transmission, which was not considered important. It was thought that it's only droplet. And that led to this thing, do gas ki duri, if you keep a distance of 2 yards and everything is fine. That was not fine. So airborne transmission is becoming more and more important, and which is actually evident in this outbreak. If I talk about the city of Delhi where I am, the way it is spreading. So summarizing it, that fomite transmission is less important. We can't rule it out. And I believe that, the immediate touch, within half an hour, within 1 hour, touching a thing might lead to transmission, but much less than. So airborne transmission has to be, talking about PP on a lighter vein, in the outpatient wearing shield and all. I learned the technique of communicating, isharon se jaise baat karte hain logon se, that we learned to communicate. And the way I had to shout to be heard, the communication was very bad. I do bronchoscopy and E-bus. My vision was very bad, and E-bus required a little bit of, acuity and all those things. It was actually very difficult to do that. The other thing, we found out that quality of PP. I can talk about my city. Delhi is full of adulteration and corruption. So sometimes
not on national TV, sir. Here.
Sorry.
Go on, sir.
No, we are a small. So they were PP when the sweat came out. They were porous. And my younger colleagues, I didn't go in the ICU that often. They used to come, sir, ye kya baat hai? Hamara kya protection hai? Then we'll go and fight with the administration, get better PPEs, sometimes ill-fitting PPEs. So all those things. This is not the question, but I just wanted to talk. Thank you.
So can I ask, I know this is not my brief to be discussed, but can I ask Anand, so when you take rounds in Tata Memorial, there are suspected COVID and everybody will be an unsuspected COVID also over there. So what do you wear while you go for rounds? This is for the, this is what I was the one who actually suggested this PP topic. So I would like to ask everyone ideal protective gear for OPD, for going to an emergency, a ward and ICU. These 4 things we would want to, summarize for all our audience now. So Anand, with you, let's start with the ward.
So when I go for rounds in the ward, it is just 2 masks. I mean the N95 and the normal surgical masks, and hand wash. That's it. This is patients who've already been screened, so they are not COVID positive. So after every patient, I just make sure I hand wash, and both masks are mandatory. And we have now shifted to scrubs. Earlier we were not using scrubs. Now all our work, once we reach hospital, is in scrubs. OPD is the same thing.
So one second, Anand, just 1 second. So what you're saying is for rounds, you put 1 N95 and 1 surgical mask, and that's it. Yeah. And just scrubs, that's okay. And do you use face shield or goggles?
So I was wearing the face shield, and I couldn't see anything. It was just very difficult. So I tried it initially, and then I said, you know what, I can't do that. So I just wore the mask, right? I didn't wear the face shield. No.
Okay. So can I ask Dr. Amol Patel, do you think that is right, sir? How do you?
Oh, my decisions mainly now based on my wife's decision. So
Sir, that is everyone's. Now, no, your concepts were wrong for 25 years before.
So, so basically, I don't use two mask. Only one N95 I've been using. And,
Okay.
So as
face shield?
Hospital, yes, I'm using face shield.
Okay.
Whenever I'm see the problem again, the new problem has arisen for us. It's ICU, yes, for people there, it's a complete PPE, full PPE, no problem in them. But for us now, when we are taking the ICU round, there are problems that the RT-PCR negative patients are coming.
Sure.
And there's a lot of issues. Whether
that is exactly why I'm asking you, because in Delhi, in the last 15 days or when we do grounds, at least 3 will be shifted to be suspect COVID ward.
Yeah.
So, I mean, what is the difference? So that's why I wanted to ask.
So this is level 2 PPE we are using. So basically, it's an N95 face shield, head cover with the surgical this thing, and the gown. So we are at our hospital, we are using the cotton gown. So that can be easily washed and they come again. So after autoclave. So, gown, cotton. So they're quite comfortable, but certainly yes, it depends. The humidity in Mumbai goes to 85%, and then you had it. But level 2 PP we are using in such situation. Those are in the COVID ward.
Fine.
They are using complete PP.
I will come to COVID ward by asking the intensivist. I think Dr. Sheila wants to make a comment.
So I just like to say, as Dr. Khilani rightly said, over time, this fear about fomites has definitely come down. At home, we were doing ridiculous things. The way we were cleaning our vegetables also everyone was so paranoid. So over time, that has evolved. In the ICU, definitely, we are concerned because we do aerosol generating procedures. And even what is an aerosol generating procedure has been debated. People have even challenged that tracheal intubation, when you give a muscle relaxant and you do a laryngoscopy, is not an aerosol generating procedure. And they even say that someone who has a very violent cough or a partially obstructed, like in a ward, a tracheostomy, or someone, speaking, and even these things can be aerosol generating. So that is the reason people tend to err on the side of, more protection and wearing an N95. But if it's not an aerosol generating procedure, this is a droplet infection. You really don't need to wear a N95 mask outside of the ICU. But I can understand that people want to stay protected and they do that.
Sure.
But the man on the street wearing an N95 mask is what I find quite ridiculous, because that is really not required. You see a lot of people on the street wearing.
No, but Dr. Sheila, that N95 will be down till the chin, not covering the nose. So that's
right. So I think it's more important is not whether you're wearing N95 or a surgical mask, but how appropriately you are wearing it. And I'd like to say that even in the ICU now, not only in India, we wear a full PP at Tata Memorial in the ICU, but many centers across Europe and America now are not wearing full PP. They're very careful about the protection as far as the mask and the face shield and the goggles are concerned in the ICU, and wearing gloves. But they would wear a gown, not necessarily a full hazmat suit and a full PP. So it's a little modified. Because the concern is more the respiratory than the fomites.
Okay. And I will now like to...
Level 2 pro, yeah.
I'll ask Dr. Badira, OPD, what do you feel is the right thing? So I can tell you, in my first wave, we had that plastic shields, we had the N95. So what do? You're a pediatric oncologist.
Yeah, I mean, so you're right. So in the first wave, we used N95, the double masking shield, which is actually also the recommended thing. You need to protect your eyes and the nose. So face shield and N95 is required. But having done this over the last many months, like since over a year now, we have, as Anand has rightly pointed out, we have come to N95 mask mainly, because face shield has become a difficult thing for us to write and all those things. So, and we maintain a distance. So we maintain a distance and we use hand rubs very liberally. So hand sanitization and N95 is what we are going.
Okay. So can I ask, Dr. Dheeraj, you wanted to add, please go ahead.
So what I want to say is that from our ITU perspective, we were very worried about this virus in the beginning. But what you got to realize is it's one of the safest environment to work, because all of our patients in ITU at that time were intubated. Every circuit was closed, no spread of the virus. The people who got the most infection during our first wave were people in the respiratory wards who were using CPAP and high flow nasal oxygen, because that was where all the aerosol was being generated. You would have initially also seen at that time that we had some weird kind of boxes, perspex boxes made for intubation, which a lot of people then found out was a reservoir of COVID infection. So as Sheila has added, and a couple of you have added, we have completely downgraded ourselves in terms of our PPE. It was a study in the initial phases showed that people in ITU got less infection, or doctors got less infection than the others. Remember, doctors get infections from other medical staff. They never get it from the patients. And this is a very well-known fact during the COVID pandemic. So we use a FFP3 mask, and we use a shield and a gown. That's it. And that is if we are doing aerosol generating procedure. Now with the COVID patients, which are very less in our ward, we just go with a simple pinny, glove, and then some people wear FFP3 mask, some of us wear normal surgical mask, and that is quite acceptable. I think we got to understand that even though we're saying it's not airborne, it's aerosolized procedures which generate this. So if you're just speaking to someone you're greater than 1 meter, you're never going to have droplets which is going to drop on you and cause the infection. So as long as both of you are wearing masks, you protect each other. So that is where we are at present. And I think ITU is a very safe environment in terms to having these kind of protections.
I think sitting at your home and having a Zoom meeting is the safest environment. Okay, Dr. Khilnani, sir, Dr. Sheila, you, and then Dr. Khilnani, can you summarize in 2 words, OPD what to do, ward what to do, ICU what to do? Dr. Sheila, you first.
I think Dr. Khilnani will summarize it. I just wanted to add a point when you said the infections for the healthcare workers went down, but what really went up was the infections to the patients. And they already COVID positive, but the other infections. I think in COVID era in the ICU, people completely forgot that there are other infections. Yep. And this happened, with all the intensivists and also my colleagues working overseas. And we had a rise in nosocomial infections. And general infection control measures were completely forgotten. People were so obsessed with protecting themselves, and that it was this was something that was never so much a concern as it was in the COVID era. That, as I think Nandita mentioned, they completely stopped hand hygiene between patients, changing gloves. All this stopped, and we saw a steep rise in the VAPs, the CRBSIs, the UTIs. So all the other nosocomial infections were on the rise. And this was a real concern with PPE use, because everybody was thinking, oh, am I getting infected? Can I get infected? And they were just obsessed with protecting themselves. I think Dr. Khilnani will take the...
Dr. Khilnani, sir, OPD. I'll ask you simple questions, sir. If I can ask you.
So I'll ask you tell you my lifestyle. Sir. What I did after COVID. I used to keep 10 sterile gowns in my car. In the basement, as I get down on my car, I'll put on the gown and double mask and the shield, not gloves. And then I will take off that gown only when I return back to the basement. And in the OPD, I had made a L-shaped, or you can say whatever shape you call it, a glass. Pakka glass ka, and then like you have in embassies that papers can be slid over, that we all ordered, and we used to do that. And I must admit, we almost stopped auscultating patients. Being a pulmonologist, it was difficult. If at all, my younger people were auscultating and telling me their findings, and we were using gloves very often. And over a period, I've learned, and I have got a conviction that majority of the infections that healthcare people got, they got from eating together and drinking together. It was not from seeing patients, because at that time you are very careful. You never pull down your mask. And it's a frequent thing that when the patient starts talking, he pulls down his mask. By the time you tell him that, okay, what the hell you are doing, he has already thrown whatever he has to throw, you know. So that's why we kept that barrier in front of us, so that, you know, we have triply protected. I am wearing a shield. But gradually this thing came down. I stopped wearing shield because I realized that if I have to auscultate, I have to pull down the shield and then again auscultate, then I am causing more harm, more risk of infection to myself. So in the OPD, I shed the shield. But while I was going in the ward rounds, I was all the time wearing all these things, including I still do that.
Can I summarize this for you, sir? So in
Sure.
OPD and N95, probably, and maintain distance. Stay away from people. Wash your hands. Sanitize yourself.
Double mask.
Double masking. Okay. Yeah. In the ward, you wear N95 plus minus another mask above that and a face shield. And again maintain distance. In the ICUs and ITU setup, partial PP, full PP, you are anyway more protected over there. Is that the right thing?
Yeah, that's
everybody agrees. Dr. Nandita has a point.
Yeah, I just wanted to, we are 3 anesthetists here in the panel, and elective surgery for us has started. So we now I wear a usual N95 mask and with a visor, and the other thing will be just gloves. We sometimes don't even wear it on because hopefully all the patients have been tested and they are negative, but you never know what happens afterwards. And the other thing what Dr. Khilnani said is our coffee rooms where we sat down to have our cup of tea would have possibly been one of the most transmissive, most important place for transmission of infection. So that's
what we did, madam, in our this thing is no two people have tea together. If I take a tea, everybody else masks up. If somebody else taking a tea, we mask up. I have not had lunch with my colleagues for last year or whatever. So
that's very good. That's excellent.
That's anti-social.
I would like to add that it's not only during speaking and eating together, but it's not from the patient, but your colleagues and your friends and family that people have got COVID, because they always think that these people will not be infected. It's always, they always think the patient or the relative is infected and not our colleagues.
Okay, so I must tell everyone that this was not my brief to discuss the PPs, but as Amish and I are compulsive moderators, as I can say, my topic of discussion today for the next some time would be corticosteroids, COVID and cancer. And
Ullas, can I just tell you,
sure.
Please don't hurry up your discussion. It is very important. And if we run out of time, we'll continue yours the next time also. Okay.
Meko to question hi puchna hai, sir. I don't have to answer, so I'm absolutely okay with that. Okay.
Can I submit, Dr. Ullas, one question
sure.
for our international faculty?
Sir. You were the moderator of this. You are the boss.
But you took over.
I know. Compulsive moderator, I told you, no? Tell me, Dr. Amol.
You start listening to your wife, then the things will be much easier.
15 years and counting. Go on, Dr.
Amol. What's about the AC environment, central AC? Is there a fear is still going on, or any changes? I don't know, with the OPD environment are so crowded now. In fact, in February, we had almost 40 patients along with 40 plus 2 in a small room. There were almost a crowd of 80 patients, 40 plus there, one attendant was allowed. So what is this, the issues with that time when it started, the central AC used to be, closed, and also what are the hospital policies these days at our other hospitals?
You're asking us, most of our problem is we have the opposite because we have to have the heating on. But yes, nowadays we find that most of our, during the heating and all the windows and all used to be closed. Now we find suddenly it's very cold because we had 0 degrees or minus there, and because the windows were kept open. So that's there. Dheeraj, did you find the same thing in your hospital?
Well, I think there was a considerable amount of debate going on regarding this. But, I really don't think so there's any evidence that air conditioning by themselves can cause any problems. We had our things, both our theaters where we managed majority of the cases had air changes. And initially there was this thought that we should stop the air changes. Where does this air circulate? Does it go out? Will it cause more infection? There are certain isolation rooms which are there in our hospital where in the ICU, where we're thinking, where does that air change goes? Is that going to propagate any infection? I was another webinar where this question was asked, and I think most of us were at that consensus that it really doesn't matter, because I think the thing that it's like airborne which can spread through an AC has not been ratified anywhere, and I don't think so. That was the thing. We thought it was more dangerous to actually not have the air changes going on in theaters, and what we found in that situation was we just continue our practice as it is, and I don't think so that has caused much of a change, but I'm happy to hear other experiences, but we've not had any problem with that at all.
Yeah. I'd just like to share about the intensive care unit, if I may. So we have different sections in our intensive care unit, and we thought we would, keep one set of patients in one place. And then when I spoke to the engineering department, they said, look, this is common air handling. It doesn't matter where you keep your patients, because, the air handling is common. So the virus will be, even if it's in another section, the virus will circulate. So it really depends on the number of air changes. So the minimum recommended is 6 air changes. So the more air changes you have, the more protected you are. So that was a very important thing, not only in the intensive care unit, because you need to know what are the air changes, but especially in the operating room, because you need to know the number of air changes, especially between patients. You finished one case and then you're taking the next case. So you need to know what are the air changes in the operating room. So this, the number of air changes that you have is important from clearing the virus point of view.
And it depends on where these air changes go to. You have to be very careful of that. Like we had a couple of isolation rooms where changes were going into the main unit. So it is the only reason of having all that and continuing with those changes was that even if it was vented into that area was treated as a COVID area. So anyone who's going into that area would normally be wearing the full PPEs. So in that way be protected. So these are, like, I agree with what Sheila said. And these are the considerations to be actually had in that situation. Most of the ACs, I think the air is going to be vented out, so you wouldn't have much of a problem there in that situation.
Yeah. So I'd just like to make a clarification on that quickly. So there are two things. One is the positive and negative pressure isolation, and the other one is the air changes. So the air changes is the thing that clears the virus. So the more air changes you have, the faster there will be the clearance. But the negative and positive pressure are different. They don't protect the patient, but they protect the healthcare worker outside. So if you have a negative pressure room, the pressure is differentially negative inside, so it contains the virus within that room. So when you have a negative pressure room and you're doing, say, an aerosol generating procedure, you're doing a bronchoscopy or something within the room, the person outside, the healthcare personnel outside are protected because you don't have this going outside. But this is only seen in the intensive care unit. Very rarely do you have negative pressure rooms. In operating rooms are positive pressure. So this is very rare to have a negative pressure room in the other areas of the hospital.
Okay, thank you.
Anybody else? I mean, like, we opened the, our windows were tight sealed in the OPD. We actually removed the seal and let the ventilation come in. Anybody else who had the same thing? Amish, kuch kiya aapne hospital mein?
I think at Sir Gangaram Hospital, Shyam Agarwal was sharing that they did the same thing. They had central AC which they discontinued, and they, put wall ACs so that there is no common air circulating in the hospital.
But even opening the windows, as you rightly said, is a good option if you don't have, that's a good way that at least there's ventilation.
For last 1.5 years, again, the air conditioner is still there, but the windows are open. I mean, and sometimes, it actually fell down once also. So, okay. Anybody else has a question regarding this PPs so that I can go on to my steroids thing or any other thing? Amish, with your permission?
Yes, sir. Please go ahead.
Okay. So let me share my screen once again. I think we'll have 15 minutes to discuss some bit of steroids. So my first reactions when I actually thought about corticosteroids, COVID and cancer was, again, dexamethasone was hailed as the game changer in COVID-19 battle somewhere in the month of June, July, to the recent mucormycosis, black fungus in the COVID positive patients. And as I told in the last one, the truth usually lies somewhere in the middle. and today we are going to discuss about the steroids. So this was some article which came in Nature at that time, and what it basically showed, what the crude mortality in their study was higher in the patients treated with corticosteroids than who did not receive. These are initial articles which came, which said that steroids may not have that much of effect. To the NEGM, the famous recovery article in February 25-21, and where they said a lower mortality rate with people receiving dexamethasone, and with that, dexamethasone actually went out of the pharmacy shelves, and everybody used to give them dexamethasone even in mild, moderate, severe. But again, the truth lies somewhere in the middle, and we're going to discuss that today. So I will start with the who, why, where, and when. Amish, the first question goes to you. How does steroid actually work in COVID-19? Is it the immunosuppressive? Is it the immunomodulatory? Why is it effective in COVID-19 when it was not very effective in MERS, etc.? So why?
So MERS, I don't know. But today only Dr. Prashant and I, we were discussing about exactly the same two papers what you have put for steroids.
And you copy on my laptop sometime? Do you have access to my laptop?
You will be surprised what all access we have, Ullas.
I am not coming to this remote access.
Okay.
So I think, can I request, because Prashant has worked in ICU and COVID wards a lot, can I request Prashant to answer that question? Ullas,
Sure.
You are okay?
I'm absolutely okay. Prashant?
So just thank you so much, sir. So just something about the pathophysiology. I think we are now reasonably, we know that it's not actually a viral pneumonia. It is actually it's an inflammatory and immune-mediated disease. Immune-mediated lung damage is very akin to GVHD, lung GVHD. So it's an immune storm. So all the drugs which work in GVHD, acute GVHD of lung, although acute GVHD of lung also is very uncommon, but when it happens this way only. And all the drugs like steroids and tocilizumab and Janus kinase inhibition, ruxolitinib, ibrutinib, all that is what works. And this is what has been shown to be in preliminary data to be working. So I think it is more of an immune-mediated disease, immune storm. And I have also, many of us may have seen some immune cytopenias also after in the recovery period. So it is probably some form of autoimmunity. So that is why steroids are working, but not in the initial viral replicative phase.
We will come to that
phase. I am sure you're going to discuss that.
So let's come to Dr. Badera. I mean, pediatricians are usually very academic and, not like medical oncologists. So Dr. Badera, did some search. Why is it working? Why not working? What is your take on that?
Yeah, so as pointed out, so as we know, after the viral replicative phase, the inflammatory storm that sets in during the second week of phase. So the steroids mainly is the anti-inflammatory effect of steroid is what we are seeing, and that's why we need only a low dose also to combat that inflammatory storm. So the low dose particularly, so it's mainly the inflammatory surge that happens in that phase where the steroid is acting, and it has been effective in that severe COVID and has not been shown to be any effective, and it is not recommended in non-severe COVID patients.
Okay. I'll come to Khilnani, sir. Sir, pulmonologists and steroids, they go hands in hand together. I actually heard a lecture, I don't know who gave, what will a pulmonologist do without steroid? So, sir, your take on this, why does it work when it doesn't work in MERS, works in SARS? How does it work actually?
Yeah, that's very true. But you don't forget H1N1, where also it doesn't work.
Yes, sir.
And corticosteroids in ARDS is always a pro-con debate, which is going on for 3 decades without any answers. But same was thought of COVID also as it came, because COVID also causes ARDS, and hypoxemia, and cause of death most often is severe hypoxemia. Initially, we all thought that it does not. It will cause harm because from the SARS-1 outbreak and also from H1N1, where there were distinct increase in the mortality with steroids. But the recovery trial changed the game, because it is, and of course the mechanism very nicely outlined by all of you, so that is there. But if you permit me, I would take 2 minutes to say how do we use it in the clinical part of it, and why this black fungus and mucormycosis have come into What has happened that in the absence of an effective antiviral drug for outpatients, if you leave aside remdesivir, to my mind, favipiravir doesn't do anything. So clinicians are at a loss as to what to give to the patient. HCQ doesn't work, doxycycline doesn't work, and ivermectin doesn't work. People are giving antibiotics. So with this recovery trial, on the day one, as the patient is diagnosed, patients are giving steroids. My take on this is that steroids work as anti-inflammatory. If you give in the viremic phase, that is the first 5 to 7 days, they cause harm. They will lead to higher degree of viremia and more damage than benefit. You have to document that there is an inflammatory process going on by means of doing inflammatory markers, which I need not narrate. We do it all the time. I don't know whether I'm answering question or making my thought process out. That
you are teaching us, you are educating us, and we are thankful for that.
But in this disease, which is primarily exemplified by inflammation, and the D dimer is also in the COVID is not a marker of thrombosis. D dimer in COVID is a marker of inflammation, although there is evidence of thrombosis also. So if you give steroids at an appropriate time, and I need not recite that because I'll go on for a longer time, then only they will cause benefit. But what has happened is that people have gone in supranormal dosages for supranormal time with a total disregard to the sugar control.
I will come
and
to
that has caused the damage. So I don't know whether I've answered or confused me, but if there is any pointed question, then I'll be able to.
As I told you, sir, you have educated us, and we are very thankful to you for the pearls of wisdom. So Dr. Sheila or Dr. Nivita, I mean, what is your take on this?
Yeah, I'd like to echo what Dr. Khilnani said. Firstly, the recovery trial showed harm when it was given in mild cases. So it is recommended only for severe and critical cases. Now, what happened as intensivist, the steroid thing, like, firstly, the question was whether COVID is an ARDS at all. That itself was a big debate. It's a cardiovascular disease, or is it an ARDS or not? And we've always debated about steroids. Now, whether you're looking at sepsis, or you're looking at ARDS, or any of these conditions, they're all pro-inflammatory conditions. So why is it that steroids have not really worked? Not in H1N1, not in SARS, not in these conditions. So these were the questions. And actually, in the beginning of the pandemic, we were not using steroids at all. And then came this recovery trial, and with low doses. So we're looking at immunomodulation. We're not looking at immunosuppression. And like Sir has rightly said, not in the phase in the initial 1 week where we're looking at antivirals to work. It has to go in the second week, around that time when the patient has severe, is oxygen dependent, has severe COVID, severe or critical COVID, and needs anti-inflammatory action. It can actually be harmful in the initial viremia phase.
Okay.
So this recovery trial really changed the way we were looking at delivering steroids in this condition. In fact, a lot of people were not convinced until they had this large trial that steroids would actually work in COVID.
Okay, Amish has a point. Amish?
Yeah, I just, Ullas, as you said, we are compulsive question answer asking people. To Dr. Khilnani and Dr. Sheila, who have answered your question. The practical problem is that pulmonologist or COVID expert comes into the picture the moment COVID report comes positive. But let us not forget, Sheila, that in the community, when you say the viremic phase is very, very haphazard thing.
Amish, can I stop you for a moment? I will have that question right now coming up for that. Okay. I'm sure you have access to my mobile, to my remote, to my laptop. This question goes to Anand. Anand, so just one word answer. When and when not? When not will you give corticosteroids to someone with COVID?
So I think the answer in mild and severe is very clear. Mild you don't, severe you throw the kitchen sink at it, right? And that's where the intensivists come in. What about moderate? And that's where your clinical acumen comes in, which is why you do all the inflammatory markers, you monitor their stats. So we give steroids in moderate because the severe ones went to the ICU. And whatever recovery rates we saw in our moderate COVID patients, we attributed it to COVID, to steroids. So we gave steroids, and initially there was decent data for remdesivir also. So in moderate, we gave a combination of both, and we were able to recover a fair number. That's my take on it.
Okay, and that is what I think everybody, and I'm sure not even Amish, but Dr. Sheila also has access to my laptop. And that is what I showed the recovery trial, diamond to the right. If somebody doesn't require oxygen, I mean, that's a point which needs to be told to everyone. If somebody doesn't require oxygen, you're actually doing more harm. Dr. Sheila.
I'd just like to add that steroids are to be given in a patient who is oxygen dependent. In the recovery trial, they gave it to patients who want 10 liters or more of oxygen. So it is not for a patient, this becomes severe COVID. It is not for a patient with mild to moderate. So this is a patient in whom you're starting oxygen. It's not based on your values of inflammatory markers at all. The patient is oxygen dependent. That's the cue to start steroids. That's what we started in the recovery trial, and that is what is shown benefit. Now, what we're doing is, when I say early, it may be 10 days into the disease. It may be not at all in the disease that the patient is oxygen dependent. So it's not that everybody requires steroids. And what we've landed up now is a mess where you've got a COVID positive, RT-PCR positive report, and people are starting dexamethasone.
I think we have 2 points. Anand, you have a point? Yes, Anand.
Oh, yeah. So the oxygen dependence cannot be the only criteria for severity. In a patient who is in the ward with high spiking fevers, with a high respiratory rate, with maintained SATs, where you have possibly given remdesivir plus minus, and you cannot wait for that patient to deteriorate and be shifted to the ICU to start steroids.
Anand, I got your point. Your point. I'll ask Badera and then Amish, and then I'll show you my case, and then we'll stop. Okay, Dr. Badera.
Yeah, so yeah, again, as Dr. Sheila and Dr. Anand pointed out, so this we have to be very careful about where we start steroids. So there is what is known as happy hypoxemia also in COVID. So you have to know the whole clinical context of the patient. So a patient who is having 93% oxygen, who is otherwise okay, and he's safe on, and you will definitely, they will be putting O2 off for that patient also. But if you have a SAT with a 93 or 92, but the patient is having this respiratory distress, there is accessory muscle use, there is subcostal retractions. So these all put into a patient, even though the stats will not come into less than 90, but still that patient, even between 90 to 94, is a patient on a downward trend going into a severe COVID. There you should put steroids. Otherwise, a patient who just has a 93% HCO2 but is otherwise comfortable, I don't think there is a need to start steroid in that patient.
So I agree with Badira. If a patient has respiratory distress, 100% he should be on oxygen. So this would be a patient who would be oxygen dependent, because we don't have any evidence for somebody who's not oxygen dependent just because they're having fever or just because they may decompensate that we should be starting steroids on them.
Okay, that's again Dr. Khilnani, sir, you please.
So I'm against the tide while I'm talking, and this is based on the fact that you have to look at the patient in general.
Yes.
I need not recite the patient who are at high risk of death. That is one. Suppose the patient is on the 5th day of his illness. He has a lot of cough. The CT is showing pneumonia. His score is something like 12 by 25 or 14 by 25. He is not yet hypoxemic, but his CRP is 90. D-dimer is on the higher side. I wouldn't wait for him to become hypoxic. I would start him on steroids, preferably with remdesivir. The dictum is that you should not give steroids without effective antiviral therapy. But I think by the time the hypoxemia occurs, you are waiting too long. The best benefit of steroid is before the person becomes hypoxemic. Why in ARDS with H1N1 steroids did not work? Because we were giving steroids to people who were already in ARDS. Here we are giving steroids to people who have not yet gone into ARDS. That's my thinking and take. If you agree, fine. It's otherwise okay.
Sir, can I just now summarize 2 schools of thoughts? One school of thought which I totally agree with is everybody has access to my slides. Without me sharing with someone, I'm going to change the password because that's the same case I have put across over here. I need to change something. The second thought, let's say this patient, a high-grade fever, has got COVID. On day 5, the CRP was 4, HRCT was done, the severity index was 4 or 5 on 25, continues to have cough, continues to have fever. repeats the CRP on day 7. In 2 days, the CRP has become 32.7. Saturation still is 95, is not requiring oxygen. CT scan was done. It has also doubled, it was 4, it's 9. If this guy comes to Dr. Khilnani, probably he will go ahead and give steroids. Dr. Sheila, typical definition of recovery, you will not give steroids. And there is where my role comes in. There is where the truth lies somewhere in between. So what would you do?
Are you asking me?
Yes.
No, I would not give this patient steroids.
Fantastic.
At this point, with a saturation of 95, if he's comfortable, he's done a 6-minute walk test, he's not desaturating, I would not go by the CRP value alone. I would just look at the patient internally. I would go purely clinically to tell you see signs of respiratory distress, that patient needs oxygen.
Okay.
So it's not only respiratory distress in isolation. As an anesthesiologist, as an intensivist, I would start this patient on oxygen, and this would be a patient who I would start steroids on. So it really depends on the clinical setting. You can have a patient with this saturation, but who can be tachypneic, who can be in respiratory distress, who will need oxygen. So it depends clinically. Really, it depends clinically.
Fair enough. So Dr. Badera and Prashant Mehta. Badera first.
Yeah, no steroids for this patient.
No steroids. Pediatricians. To the book. Good. 2-1. Prashant. Come on, Prashant.
Yeah, so by day 7, if they're high spiking fevers and CRP is climbing, I would start the steroids. No doubt whatsoever about that.
Wow. Okay. Dr. Dheeraj.
Well, I mean, it's not, I'm siding with my intensivist colleague, but I think my thoughts would be exactly we started steroids last March, even before the recovery trial came. And our logic at that time was very simple. It's a biphasic disease. By the time your cytokine storm starts setting in, we really don't know. We talk about ARDS. What we got to realize is that there are 2 phenotypes here, which we call as the L type and the H type. The initial part, we believe, occurs due to a pulmonary vasculopathy. And then the patient starts breathing. That causes what is called as your PCLE, patient spontaneously breathing induced lung injury. That causes the lung changes to come, and then your patient goes into an ARDS picture. Okay, so this stage might occur before, or it might occur after they've been admitted to the hospital. But what I completely agree is that if a patient, you might find that a lot of patients have a saturation of 95 present with the exact same scenario. In the next couple of days, they settle and they get better. They never require steroids at this stage at all. It's only in a small group of patients where they go on oxygen and then start developing problems that we start them on steroids. But steroid generally is not bad because, as pulmonologists know, there was a trial in JAMA which showed that if you have pneumonia with septic shock, you start them on steroids. If you have a viral pneumonia of any kind, you have got bronchospasm, bronchitis, you start them on steroids. And you rightly said, Ullas, with pulmonologists and skin specialists, there is steroids which is used practically in everything, and it does help. And we have further stages of steroids too. Once they come into ITU and they've already received dexamethasone on the ward, we still give steroids. And as Sir mentioned, Dr. Khilnani, in ARDS, there is a medullary protocol which we follow in patients, which is continuing steroids later on in ARDS. So they have a role. But at this stage, I think steroids have the propensity to cause damage. And I would err on the basis that unless they absolutely require and they go on oxygen or show changes or have pro-inflammatory cytokine storm, which is evidenced by high ferritin at that time, you have got your LDH going through the roof, your D dimers are quite high, everything which points to that patient having a cytokine storm. By the time on which invariably the patient will be on oxygen, you will give steroids. So I think all of us are in a theoretical aspect. This patient will either get better or go on oxygen in a couple of days, in which case he'll receive steroids anyways.
Okay, 3-2. Dr. Nandita and Dr. Anant Ramaswamy after that. So 3 for no steroids, 2 for steroids. Dr.
Yeah,
Nandita.
I'm siding with my intensivist colleagues. I don't think so. No steroids at the moment, but keep a very, very close eye if he requires oxygen. And
please, again, for everyone, please imagine this is Delhi in April. People are dying on the streets. I mean, if I can say that. So probably 4-2.
Yeah, no steroids.
Anant, 4-2. Steroids, no steroids.
So obviously, this is not a winnable battle because it's already 4-2. That said,
no. You don't know how many people are there, Anand. I might just continue for some more time.
Would everyone agree that this patient would be admitted, or would you admit this patient for sure?
If
No, I mean, okay. So if you don't, then I have an issue, because I would definitely admit this patient, because he could go either way. I mean, so even though I'm a big fan of steroids, I kind of agree with the intensivist that maybe a day or two hold on, but this guy might get steroids in a day or two. So, please admit him is what I would say. Yeah.
Admit and monitor. Yes, I agree with that completely.
But where are the beds?
Okay, yeah,
To admit him, that needs to be discussed. That needs to be discussed. You can't say that you will admit and monitor. You don't have the beds.
But he
this patient can be monitored at home also. If you don't have beds, this patient can be
That is also a concern for many of our patients, monitoring at home.
So
that we understand better.
If you can't admit, I would err on the side of being aggressive and start steroids. I mean, I have no doubt on that if I can't admit, because this guy could go either way.
Fair enough. And since I'm the moderator, I'm making it 4-3 for steroids. So now it comes to Amish Vora.
Normally, I would never ever dare to say any other prescription other than Khilnani sir. Ullas, you need to understand that. But here, one of the important line in your slide is fever and cough persisted.
Yes.
So it is not a new symptom.
It is 102 fever on
102,
day 7.
yeah. It's a high spiking fever, you say. High spiking fever, day 7 and beyond.
Yeah,
yes.
If it is 102 fever on day 7 with increasing CRP and HRCT score, I would start steroids in the city of Delhi today.
Okay, so it's 4-4. So the last word or last vote goes to Dr. TP Sahoo. So Dr. TP Sahoo, this is not one of my PJs now. You are the deciding one. Tell me whether to give steroids or not. And that's my last slide for today, probably.
Yeah. So no, my point is technically he's a mild criteria. He falls in a mild criteria as per the AIMS guidelines supported by Government of India. So if he's in mild criteria and has no tachypnea, is still maintaining 95 saturation on a room air, what stops us from getting a CRP done the next day? Because that would be not a delaying in starting steroids.
Have you seen the reviewed AIMS guidelines which have shown, which have been listed mild higher risk category and consideration to start steroids? That's the latest one. Added to the guideline in mild.
So mild severe would be what exactly, Prashant?
Above 94% saturation on room air and no tachypnea beyond 24. That's the mild category, but they have listed higher risk category in the mild. That's after third.
I'm exactly coming to that. A 37 years old male cancer survivor is no way fitting into the high risk criteria.
Okay, Dr. Sahoo.
This high fevers beyond day 7. That's what is the high risk category. Not the risk category. It's not the comorbidities. It's the high risk features beyond day 7. What happens? That is what it is.
Okay, so I will take my vote.
I can share that screen if possible. I'll try to. But those are the new AIMS guidelines in the mild category. Please look at that. And that must be based on a lot of patient experiences and Khilnani sir's experience and a lot of consultants in AIMS. I'm sure of that. And that's what we are seeing happening in India right now.
So Prashant, I will have my vote. So for me, I will not start steroids. I will probably call him the next day for the blockers. So that is my take. Okay.
Since Sahoo, you took Prashant's help, I am discounting your vote. And I'm asking the panel to stop at 4-4 with a very nice view to continue this discussion on the 20th. And I hope really you all join us back on 20th on steroids. This was mild going to moderate. I'll be discussing more moderate and severe cases on 20th. Back to you, Parikh sir. And thank you all my panelists for being a sport and listening to my PJs as.
So I'll share the latest AIMS guideline in the mild disease. Home isolation, that's listed there. It says may be considered with high grade fever and worsening cough beyond 7 days only, in consultation with the treating physician.
If I may just add one point.
This is AIM guidelines.
If I may just something on this, because I don't think I'll be on any more webinars. I just like to say, as an extension of the recovery trial, what we are doing now, along with Scandinavia and India together, are doing a trial where we are comparing 6 milligram of dexamethasone with 12 milligram, because the dose really hasn't been compared, and perhaps the dose that we're giving is very less. And I'm very proud to be leading this study in India, and we have several centers in India, and it's 1,000 patient, and we have finished 970 cases. We just need to complete 30 more and we'll have the answer. We are targeting NEGM. So this is a very, very big trial. It's India and Scandinavia. and we will have the answer soon. So perhaps we may need a higher dose. And if the results show that there's no difference, then perhaps a very high dose and the pulse dose and all that we're giving at the moment is not necessary. So
Dr. Sheila, I am going to debug my laptop right now. How did you know all my questions? Okay, Dr. Parikh, sir.
Thank you very much, Ullas. Thank you very much, Amol. Thank you, all the panelists. This was absolutely outstanding. And as Ullas said, we don't want to rush the important discussion, so we'll continue on the 20th. Our next meeting on 18th is already scheduled for pediatric patients. And Dr. Venki from Cancer Institute Adyar is going to moderate. And we have 8 panelists from across India who are all pediatricians. So anybody who's treating less than 18 years of age, they should attend on 18th May, which I think is a Tuesday, right?
Yeah, it's Tuesday.
Yes, sir, it's a Tuesday.
That's a mistake that I've made on the slide. In the meantime, please stay safe, everybody. Thank you very much. And see you soon next time.
Thank you.
Thank you.
Good night.
Thank you, sir. Bye.
Bye.